Cool. So, Dr. Kanchwala, thank you for joining us and welcome to the Deep End.
It's my pleasure. Thanks for having me.
Yeah. So we were just talking about this. Obviously, we love microsurgery here. We called our podcast The Deep End, and we love, breast reconstruction too, and we know you do. Why do you like breast reconstruction, and why did you decide to make that an integral part of your practice?
That wasn't really the plan. I like micro. And I liked micro when I was a plastic surgery resident, mainly because it was technically challenging. They were the bigger cases. And so when I left training here at Penn, I went to MD Anderson mainly because I wanted to do big cases and big head and neck reconstructions, and I enjoyed that a lot. Head and neck, lower extremity reconstruction. When I first started, I was all over the body. And I kind of fell into breast reconstruction. It wasn't really by design, although I wish it was. If I'd known more about myself, I would have designed to practice this way. It kind of was what the need was. I was very aggressively pursuing head and neck reconstruction, and then the head and neck folks here hired their own microsurgeons, so I couldn't do that as much. And my practice just started to grow in breast reconstruction. But what's been really amazing about that is that I've fallen into a specialty that I think really suits me well, personally, professionally. It's been incredibly rewarding, and I don't know that as a resident I really had the wherewithal to understand how rewarding it could be. Because the part that I missed as a resident was the interactions and the relationships you can build with patients that I think is unique to breast reconstruction. Typically in other forms of oncologic reconstruction, you fix the problem and the patient moves on with their life, and that's it. But with breast reconstruction, not only is the journey longitudinally very very long, but you're following patients. I follow patients, essentially lifelong, especially the implant patients, and so you really get to interact with them for a much longer period of time, which I've really enjoyed.
Just kind of going off of that, for some of the trainees who are listening, you trained at MD Anderson. A large portion of that is probably head and neck recon. And some of the earlier stuff that you were doing was head and neck. Do you feel that even though you're training in those other fields, that helps you in your current practice?
Yeah, it's interesting. The fellowship at MD Anderson is wonderful, and you as a fellow got to pick a lot of the cases that you'd wanted to do. So there were 8 fellows when I was there, and a lot of those fellows wanted to learn breast reconstruction and were looking for jobs in breast reconstruction afterwards. So when it came time to choose cases, they always wanted the breast cases, and I'd done so much breast reconstruction, I was one of the head and neck cases. So in my fellowship, I did a ton of head and neck surgery. And the cool thing about it is, in order to fix head and neck defects, you really have to scour the body, whether it's a fibula or an ALT or supraclavicular node flaps and all kinds of other things. It's a really toolkit that expands you throughout the body. And where I think that helps, whether it's breast reconstruction or whatever you end up doing, is just getting comfortable with operating in different parts of the body.
I want to take a little bit step back in your career journey. You went to Penn Medical School, you went to residency here for plastic surgery, you decided to stay on faculty here.
Yeah.
Why did you do that? What makes Penn so special, and why do you want to stick around here?
When I applied for residency positions, I basically told them that I was either going to go Penn plastic surgery if I was fortunate to get it, a spot, or I was going to do Penn general surgery. As in, I wanted to stay at Penn more than I even cared about plastic surgery versus general surgery. I figured you could do plastics after general surgery.
Yeah. That
was stupid because they didn't even interview me for Penn general surgery, right? So I'm fortunate that I got the spot. But I've always, this is my hometown. I'm from Philadelphia. I moved around a ton when I was a kid. I was born in India. We moved around the United States a bit as my parents were, redoing their residencies. And for me, Philadelphia has always been home. And given how much I moved around as a kid, I've sort of wanted to stay rooted, if you know what I mean. And I think that there's something really cool about Philly in that respect.
Yeah.
People from Philadelphia are from Philadelphia. Boston, New York, DC, these are different, more transient places, but people may leave, but they come back to Philadelphia, and everybody here is like that to some extent, even if they've adopted this as their home. So it's Penn and it's Philadelphia, both, that have kept me here.
And your dad's a general surgeon, so what sort of influence did he play in your life?
Dramatic. Both my parents are surgeons, actually. My mom is a GYN surgeon. And growing up, I didn't really know what anybody else did. I actually still don't really know what they do. Like the idea of going to an office, like what would you do in the office? Like what? I don't even understand that. So in my growing up, that's all this, everything we talked about at the dinner table was some case that, and I just figured that's what you do. I think to be honest, very little of my career was something where I actively pursued. It was never really in doubt that that's what I was going to do. I think if my dad was a carpenter, I'd be a carpenter. It is what it is, and this happens to be the family business. It's what I know, and I wasn't really looking for. And I think people are different now. Like you talk to students and residents. They're looking for something out of their career that maybe is a little unrealistic. I wasn't looking for everlasting fulfillment. I was just looking okay, what am I going to do with my life? My parents seem happy. I'm just going to do that. It doesn't have to be this searching forever to find something you might like to do. And then once I got into medical school, I realized I like surgery. Like any kind of surgery, even urology. When I was on my GYN rotation,
especially if you're good at it.
But there's stuff about all of these fields that is somewhat cool. When I was on my transplant rotation, I was like, oh, this would be amazing. I could be a kidney transplant surgeon, and then so you sort of just find what it is that you want to do. But for me, it was a lot of fortuitous, random little things.
I think a lot of people who fall into plastic surgery feel the same way, because a plastic surgeon is something that's such a big umbrella and not so easily defined. We're going to have different guests all the time that do completely different things. So you tend to probably have people who liked a lot of things or a lot of different things.
Yeah.
And I also think, you were saying if your dad was a carpenter, you might have been a carpenter. A lot of it has to do with who your role models are, who you look up to, the culture of it. I mean, Kobe Bryant's dad played overseas, wasn't as famous as him, but he learned all of his work ethic from him. My friend Jalen Brunson, his dad was in the NBA, so it's the same kind of thing.
It's the same stuff, and I think surgery in particular is one of those, it's always been like an apprenticeship type model. It still today is an apprenticeship type model. It's one of those things where you respect your mentors and the people who taught you, and then you want to pay that forward. When I was in medical school, actually all the way up until the 4th year of medical school, I wanted to be a cardiac surgeon. I did all cardiac research. We would work in a sheep lab and, look at reperfusion injury in their heart. I mean, that's what I wanted to do. When I was in college and we've had email for the first time, I'm a little older, my email password was the word thoracic, but I misspelled it because I didn't know how to spell thoracic properly. So that was gung-ho. It was in my 4th year that I ended up on a sub-I rotation for plastic surgery. And the only reason I picked plastic surgery was because it didn't have any call responsibilities overnight. That was the only reason. It was
a good reason.
I didn't want to do radiology. Everybody else was doing radiology or something else stupid in their last year. So I still want to do surgery, but I want to do surgery light. And the first couple days I was with Lou Bucky, who's still my biggest mentor. And the first couple days it was rhinoplasty and liposuction and breast augmentation, and everything that I had already believed about plastic surgery came true in those ORs. And I remember telling my fiance at the time I could never be a plastic surgeon because it's just, what is this? I don't even understand. The first page of the chart is the bill. It didn't make sense to me. But that last day of that week, it was, he came up to HUP, our big hospital, to do not a free at that time, pedicle tram flap. And I remember thinking, this is ridiculous. My dad's a surgeon, my mom's a surgeon. I've been doing surgery sub-Is this entire time in medical school. I've been gung-ho as you can be. And I didn't even know that this type of surgery existed. And it was in that rotation, he sat down with me afterwards and he said, look, I think you should do what I do. I do a lot of aesthetic surgery. I do a lot of reconstructive surgery. I've had such a varied career path, and I think you're going to like doing what I did. So took a year out with him doing research, and then the rest is history. And it's been amazing.
It's incredible.
Yeah.
You made a couple of interesting points. So Lou Bucky being your number one mentor. And it's funny, it kind of shows the audience that your mentor doesn't exactly have to do what you do.
Yeah.
Because clearly he's a cosmetic surgeon and you have no interest in cosmetic surgery, right? I don't want to stick on your
No, it's true. I have no interest, negative interest.
He's a wonderful guy. I think the same way about him. And it shows you that your mentor doesn't have to do what you do. He just has to guide you in the right, and be available, like you being my mentor, just be available, answer questions, advice, etc.
He's truly inspiring. And it's one of those things where you sort of, like every time you talk to Lou, even now when I talk to Lou, I'm a different part of my life and my career, but he just has a way of looking at things in a broader, longer timeline, and it's just been incredibly helpful in my career to this day.
Yeah.
That's awesome.
The other cool thing that you mentioned is like you wanted to do maybe transplant, you may have wanted to do cardiac, but microsurgery does incorporate a lot of those principles. You're transplanting tissue from one body,
Totally.
part of the body to another, hooking up blood vessels. It's really exciting, and I feel like a lot of people don't know what plastic surgery really is. There's this like horrible stigma behind plastic surgery that we do body contouring only. We only do breast augmentations. You do cosmetic surgery. But
If it's not just.
what's your favorite thing about microsurgery?
Well, I think it's hard to describe why it's so fun. Like microsurgery, like when I'm doing a vessel, it's one of the few times in my life where I'm not thinking about anything else. Like, it's just like it's
Meditation in a way.
I think it's sort of like what people do when they're like knitting something, a sweater or something. We make it out to be this like big deal thing, and it's very impactful for that patient. But the actual act of microsurgery, I think it's very just calming. Like you can't do it.
Things are going well.
Well, you can't. Here's the thing: you can't do it well angry.
Yeah,
you can't do
absolutely.
it well stressed out. You can't do it well pissed off at someone. You in order to do it well, you have to be mentally calm. Otherwise, it's just not going to work well, and it's not going to go well, and it's going to be incredibly frustrating. And so I get so easily frustrated in all other aspects of my life, but that one time during micro, it's a time you just kind of have to train yourself to be somewhat calm and a little bit more peaceful. And honestly, that's like the best time. I wish I could translate that to the rest of my life, you know?
I know.
Yeah. It makes you focus on you have to focus so intently on that all your other worries and problems and everything, I guess.
For a moment,
Yeah,
you got to
for a
hit the
moment.
pause button on whatever else you're doing.
Yeah.
Otherwise, you really shouldn't be doing that case, quite frankly.
Yeah.
It requires a level of intensity.
Especially if you're doing it for your whole career. Like you have to be calm, or else it's going to be a short microsurgery career, I think.
I think that if you aren't able to feel that way and get into some kind of Zen state when you're doing it, you won't really like it. Like, because otherwise, there's a lot about it that's frustrating at times. And I've learned this from the greats. Joe Cerletti's a perfect example. I mean, he's cool and calm all the time.
Yeah.
But particularly if you've ever been with him, and I was a resident here, in a time where the micro is not going well, he gets even calmer.
Yeah.
And it's one of those things, like that is the secret, I think, to some extent, is to really just understand, like, okay, like this is a task. Let's separate the task from the reality of what's happening and the impact this is going to have on the patient, or all the other things that you might be thinking of when you're junior attending. You're like, what's going to happen to my reputation if this flap goes down? People are going to think I'm crap, right? If you just get rid of all of that and you're just focusing on the task, bringing these two vessels together, well, then you're just going to be calmer. Another perfect example of something I've learned from Joe, and it takes extraordinary discipline to practice. Let's say he's had an artery go down. Sometimes the most common thing is to let's get quickly out of this problem, right? Let me just figure out how to York this together to make this work, because I'm living in this uncomfortable situation. The artery's not working, flaps down, what are we going to do? Well, if you try and York it together, sometimes that's actually the wrong idea. And he's a short trigger to go and use a vein graft. Mm-hmm. Well, using a vein graft as a junior attending means harvesting a vein graft from someplace, means doing 2 anastomoses when your 1 just failed. Like, it requires a lot of mental discipline to basically say, you know what, no, this is what this moment requires. I'm just going to do that. Yeah. You have to be calm. You won't be able to think properly in that moment otherwise.
Especially like investing that extra bit of time then will save you a phone call at midnight that the flap is down.
Totally. But you again, you just can't think clearly in those situations if you're not calm. Yeah. Now, some of it takes time.
That reminds me of someone was telling me a story of one of your cases, very difficult vein, where you redid the vein like 6 or 7 times. But normally in those circumstances, you would think people would get stressed. but I think you had like the Top Gun soundtrack playing, and you're like, this is where you're like, you got to turn it up, like when you're doing something.
That's awesome.
But that takes me to, I guess, one of the next questions is, now you're the director of reconstructive microsurgery at Penn, and thinking about the number of attendings we have, I mean, most of our attendings do microsurgery. We do, flaps every day of the week. What does that role entail, and where do you see the future of that?
I mean, Joe has done an incredible job essentially handpicking 15 microsurgeons. We have a large group of surgeons here, and we do an enormous volume of not just breast reconstruction, but other types of microsurgery. Our fellowship is, when I was a medical student and a junior resident before Joe came, we did a very small amount of microsurgery. This program and all of our accomplishments, the number of procedures we do, the standards we've set, that is largely a one-man, design. What my role really is about is taking a look at everything that we're doing across the region, from Princeton to Lancaster General, and saying, okay, we do a lot of surgery, and that's great. But if you look at it from a patient perspective, of course, patients want to go to some place where there's plenty of experience there. But whether we've done 1,000 flaps or 7,000 flaps, from an individual patient's perspective, why do they care? What you want to be able to tell a patient is not just that we do a lot of flaps, but that we do them better. What does better mean? Better means an aesthetic outcome that is without parallel. Better means a recovery outcome that is without parallel. So what I want to do is take the fact that we have this extraordinary amount of experience, thousands and thousands of flaps under our belt, and take that to the next level, where we now are able to do aesthetic operations with minimal morbidity. And the purpose behind that isn't just so that we can take better care of our patients. It's to set a flagpole on the moon, which is to say, this is what we can do, putting our collective experiences together so that everybody knows what the standard should be. And it improves the game of everybody else around us. And if accidentally somewhere else does something better, I want to be looking for that and immediately adopting that, right? That we want to push the envelope forward. And sometimes it requires an overview, because in anybody's individual daily life, you're just focusing on your practice and your patients and taking good care of them. Part of what the
autopilot,
and I think what this role gives me is a little bit of a license to sort of step back from my own practice a second and look at where are we headed as a group of microsurgeons.
I have a potential controversial question for you. I think I know your answer to it already, but is it possible for an intern, and I don't mean one that's at the end of their first year, but one that's maybe 2 or 3 months in, to learn microsurgery and perform an anastomosis only 2 or 3 months in?
So you're referencing our program called Penn Micro.
Yes.
And you've been an enormous part of that too.
Yeah.
Still waiting to do your first anastomosis. So the concept behind this.
You're waiting a little too long.
Yeah, I know. We got to get you in. We got to get you in. But the concept behind this was one that Liz Malfus and I have been talking about for a long time. And Liz has been amazing in being able to actually take an idea that I've had for a while, but actually making it happen. And I think it's critical, the difference. Having an idea is great. Making it reality is a totally different ballgame, right? Lots of people.
When you're so busy.
Yeah.
I mean, you can't do it.
Well, not just that. Lots of people have ideas. It's the people that make it actually happen that really, I think, move the needle. Liz is exactly that kind of person. So the concept was, if you take a look at the way I learned microsurgery and the way I've been teaching microsurgery for my entire career, it very much is a see one, do one kind of apprenticeship model. And it relies on a person, an intern, resident, whatever level, to be in a somewhat stressful environment. If the only place you can really learn microsurgery is in the OR, well, there's a lot going on. And so recently I started to learn how to play a musical instrument, the guitar. as learning an instrument as an adult is a challenging thing to do. You're not a natural like you would be as a kid, but it forces you to be really intentional about how you learn. And I think that process gave me a lot of insight into, okay, how am I teaching? And is there a way to teach better? Okay, I'll give you a perfect example. Imagine if the only time I could learn how to play the guitar was when I was in stage in front of an audience. Like, that'd be horrible. It is not how we train musicians. The other thing is, when you first started playing the guitar, when I first started, even now to some extent, it sounds terrible. It isn't fun. Like, you can barely hold the thing. Every time you go to hit one string, you hit another string, it doesn't sound good. And it requires a fair bit of practice just to be able to, like, make the notes. But there's a way you hold the guitar. There are not like 10 different ways. There's one way, right? And you need to be taught how to hold it properly. There's a way you pick the strings. There's not 50 different ones. There's like one correct one. And sports is a lot like that, right? You can have your own individual variation. Well, microsurgery is exactly like that. There aren't 17 different ways to hold micro instruments. There's really one way.
Hopefully.
Well, no, I mean, there's really one way. The instruments are designed to be held in a particular way. But like in the OR, it's impossible. What am I going to tell you? Here, I need you to focus on how you're holding the instrument, how you're putting it. Oh, no, don't tie it there. Like, oh, there's so many things to think about and focus on. And you're trying to impress me, and you're trying to not mess up, and the heart's there, and it's moving, and oh my God, the time is coming. Like, it is the most stressful thing you could possibly make it. So it's not accidental that not everybody enjoys their first micro experience. It is a extraordinarily stressful time. Well, the concept behind Pen Micro is to do a lot of that practice at home and in non-stressful environments. Exactly how I learned to play the guitar. And the first time I had to strum the guitar was in front of an audience. I would never do it again. This would be a horrible idea. Pen Micro is a video series, simple video series. Probably the start to finish is like an hour, but it's broken up into the modern attention span of about 2 minutes. And basically, what it allows you to do is practice at home in using simple things. Even practice in between cases. A lot of it is just pencils. How do you hold it? How do you connect dots?
That's what I really loved about it. Was it's not, you graduate to the instruments, but you can even practice with pencils, a paper, it's just everyday things that you're getting repetition.
What you are trying to do is to build your muscle memory, so you don't have to think about where your hands are in space. The guitar analogy is perfect. The C chord is like 3 or 4 fingers together in a particular place that you have to strum. Now, you need to be able to, in order to play the guitar, you need to be able to move from your chords, and that means moving 4 fingers into different positions. If every time you wanted to play the C chord, you had to think, okay, where's my index, where's my ring, if you had to think about it every time, you wouldn't be able to do it fast enough. Micro is the same way. You don't want to be thinking about it. I was just describing how, like, it's my happy place. I feel so calm and comfortable and zen.
Yeah.
It is how I feel about it is exactly the opposite of how my trainee is feeling about it right now. They are not in a zen, calm moment. They are not enjoying this process.
Yeah.
The only reason someone does it and goes through the training is because they really want to do this as a career. But it's painful in the beginning. So what the Pen Micro is about is making it less painful, so that when you show up, like, when I'm in the OR, that's like when I'm meeting my guitar instructor.
Yeah.
I've already practiced at home. Now, where can they get me? Where can they coach me on the little things I need to do?
But, I was just going to say, but what's so fascinating to me about it is it's such a paradigm shift. It sounds like, an intern doing micro. Most other programs maybe wait till 3rd or 4th year, where as an intern learning it.
Oh, I see.
But what I'm saying is, if you think about it, it's not that. Well, so that's how everything else we learn to do is that way. It's interesting that we've adopted this way in surgery to do it.
Part of the reason why I thought, hey, let's get interns to do micro is because it's so radically different.
Yeah.
Right? Micro is this special case. You wait till your senior levels of training before you're allowed to do it. But actually, micro, the actual putting the anastomosis together, doesn't require a lot of prerequisites. It's not like sewing regularly teaches you how to sew micro. It's a totally discrete, separate skill set that's learnable, independent of, like, some of the interns who've done anastomoses are far better at sewing micro instruments just putting vessels together than they are closing skin, right? It's because there's totally different skill sets. They're pretty good at skin too, but I'm just saying, and so it's something that's a discrete task that's very learnable. What the point of it was is to basically say, how long does it take you to learn this skill? Does this take 6 years to learn? No, it doesn't. It takes about 6 weeks. And what it means, and of course it takes 6 weeks, because it didn't take me 8 years to learn how to play a C chord either, right? I took a few weeks of really wanting to do this. And what was the motivation for me to get better guitar? I had like a date where I needed to perform. If I give you a date, 6 weeks later, you've got to do this anastomosis, and either the flap's going to live or die based off of your ability, all of a sudden there's like a really big carrot to get going and actually do it. And so that's what we showed, is that if you motivate people appropriately, you support them appropriately, and you pick good residents to begin with, which we've done, well, yeah, you can achieve something like that in 6 weeks. So now, if micro was the highest thing, that was like the most difficult, challenging thing you could learn in residency in plastic surgery, and you've mastered that, or mostly mastered it in 6 weeks, everything else is going to be a lot easier. And all of a sudden we're like, maybe we don't need to wait to give people opportunities to do these things till some, randomly defined time point. Maybe we can sort of think differently about it.
Yeah.
I think the field's moving that way.
No, absolutely. I think back, coming in as a PGY4 after doing general surgery, I wish I had those first few years, because a lot of it is muscle memory. And just like everything else in life, learning how to read when you're younger, learning how to ride a bike when you're younger, learning how to ski when you're younger, like just starting earlier, practicing, like it makes total sense. And that's one thing that I think the independent track, in retrospect, I wish I had those first, well, now that you're initiating it, because you're right, it shouldn't be a specific time point. Everyone's different. Somebody could be ready to do a microanastomosis 6 months into an intern year. Why make them wait till PGY4?
But you mentioned, and I think it's critical to get this, learning when you're younger, it's not just about your age or the plasticity of the young mind. When you're a little kid and you're learning how to ski, and you fall 1,000,000 times, you are not even remotely worried about someone judging your ability to ski.
That's huge.
When you are learning as an adult,
yes,
and you suck at something, it is much more difficult for you to basically say, hold on, I know I suck now, but I'm going to be better. That's a much harder thing,
It's very hard.
And it requires, to be honest, in plastic surgery training and surgery training, we do a pretty good job of teaching, like, skills like pen micro or something like that. What we don't really dwell on is, how do you sort of mentally, emotionally go from being scared to being confident?
Absolutely.
Right? Because it's scary what we have to do, and what we want is appropriate confidence, so that when you're faced as an attending with a new challenge you haven't experienced before, maybe no one has seen before, can you be creative? Can you rely on your fundamentals? And do you have the confidence to know, no matter what, I'm going to be able to get through this? That's what you want. And it requires a certain level of fearlessness and almost childlike, thinking to be able to get there.
What's funny is that we're digressing a little bit, but I think it's important. So what's funny is that I always used to have a neuroscience professor who would always say, when we're getting ready to prepare for an exam, is the common practice would be study and continue to study the things you're very comfortable with, and leave the stuff that you're very you're afraid of
till the end,
to the very end, which is almost similar with surgery. And I went through this my first few years of training, where the things I sucked at, I almost avoided a little
Correct.
bit.
Of course you will.
And then once you see that you're making some improvements, you build that confidence and stuff. But it's very easy in surgery to be like, I'm timid in front of this attending,
or I just don't like this,
versus whatever. So the audience needs to know you have to push through that. You have to, because
absolutely
time keeps going.
Yeah.
And as time progresses, it's only going to get more and more uncomfortable for you to perform in front of an audience.
It is strange to be able to say this, but you can go through a 6-year residency and really avoid a lot of different kinds of surgery if you wanted to, or if you just didn't feel good about it.
Yeah.
And I've always been impressed with residents who struggle with something who then can overcome that struggle. I'll give you a perfect example. Anthony Wilson, I don't know if you know him. He impressed me more than almost anyone else because he knew he wanted a career in aesthetics, and he just didn't like micro. He would tell me he just didn't like micro. And I remember his entire PGY 5-year, when it comes time to anastomosis, he'd be like, so you just do it. I'll close the belly. I'll focus on the belly. And I was like, all right, sweet. I'll get done faster. So I'll just do that. But then he as his chief resident year, he realized, look, this may be the last time I do micro. Like, let me get the most out of this experience. And he really practiced at home, and he got to be a pretty damn good microsurgeon by the end. Yeah. But it required intentional effort on his part. And I think what you said exactly right. You need to have a mindset of, look, I'm going to dive into the hard things and not care about sort of being judged. And you also,
it's tough to do.
Well, you also need to be in an environment. I think this is where we at Penn excel. Yes, you need to be in an environment that allows you to do that, to not feel like people hate you because whatever, or think ill of you as you're trying to learn, because it's a scary thing that we're asking people to do.
Yeah. And I think the important parts because we want to ask you some more questions, but I think the important parts about Penn Micro and you, and even today when I'm teaching the residents, I say a lot of the stuff that you used to tell me. Like, I used to always say, take 2 deep breaths before. So I don't know if you remember this.
Yeah.
Like, nice deep breaths. Make sure the table position's at a good height. All these little things that will just take the time to set yourself up for success, and then hit it out of the park. And
the 2 deep breaths thing, that's like the best thing I ever got out of a grand rounds. No, well, so that was a grand round. Somebody, I think Josh or someone, had a wellness speaker come to one of our grand rounds, and I was basically asleep in the corner. I rarely paid attention to that. I was like, wellness, oh my God, another one of the things. And she gave, I can't even remember her name, but I love this talk. She was talking about Olympic biathletes, and these are the guys that are basically doing intense aerobic activity because they're doing cross country skiing, and then they got to stop and be able to shoot, at a distance. Well, in order to be able to hold the rifle still, to be able to shoot accurately, you've got to be pretty damn calm. You have to be super calm. How do you do that when your heart rate's going like crazy? And what it is diaphragmatic breathing, where you take 2 or 3 big breaths, you activate your vagus nerve, and it brings the heart rate way down all of a sudden. Wow. And that's what I've been doing.
It's like meditation.
It is. Yes. And it's really effective.
It makes me think about the routine at the foul line. Everyone takes a couple deep breaths. They have their certain dribble or routine, but it brings everything to center, and you only focus on that. And then,
Yeah.
Awesome. I want to look a little bit forward now, and maybe one of the things of the future of micro is training earlier and earlier. But what are some of the other futures of microsurgery that you're looking forward to, or that you can expect?
Well, I think until we find a solution to rebuild a breast without doing microsurgery, we need to now try and make microsurgery less impactful on the patient. So, one of the things traditionally, this surgery has been a big surgery, as in it takes a long time to do, and any surgery that takes a long time to do, you put a patient under anesthesia for 8-9 hours, and you give them a couple liters of IV fluid, which is required if you're going to be, under anesthesia for that long, they're going to wake up feeling terrible. They just do. You do a revision, mastopexy augmentation that takes 2.5 hours, patient wakes up feeling like nothing happened, right? And yes, some of it is what you're doing, but a lot of it is how you're able to do it. So what I want to do is, and we have the skills, and we have the ability, and we have the collegiality to be able to accomplish this goal, is to take microsurgery, free flat breast reconstruction specifically, and move it into the outpatient realm. So what do I mean by that? And there have been some groups that have done a limited series of this. It's not like this is a new idea, but in a major academic center, at the volume and the scale at which we operate, to be able to transition to largely outpatient or 23 hours observations and then home would be a game changer. We are already there from a pain control and pain management perspective. Largely, the minimally invasive procedures we're doing now for the harvest on the abdomen is not that different than an abdominoplasty, which is an outpatient procedure. And we can get to the point where monitoring is able to be done as an outpatient. we're already at an incredibly low take-back rate.
Yeah.
Right? So now it's the question of what are the hurdles to being able to activate skills that we already have to be able to, from a systems perspective, make sure that this happens. There's a couple things, important barriers to overcome. One is insurance. Right now, free flap breast reconstruction is an inpatient DRG. The hospital will lose money if we start sending these patients home. And so we need to negotiate with payers to be able to make sure that we can still offer the same procedure and have the hospital still financially be, made whole, number one. Number two, we need to make sure that if we're going to make that kind of a transition to an outpatient realm, that we have the support on the outpatient side. I don't want a patient just being thrown home without support at home and the ability to have folks that are dedicated to them. So we need to transfer some of the work we're doing on the inpatient side into the outpatient side. But patients recover better at home as long as they're supported well. And I want it to be that if a patient's trying to decide between implant breast reconstruction and free flap breast reconstruction, they're not told, well, you could be in the ICU for 5 days, with a morphine PCA like we used to do, or you could go home. You decide, which, they're both good options. That's actually not true. In reality, you could be home for both of these. You could be taking relatively minimal pain medicines for both of these, and you should pick the surgery that fits your life better, right? Two surgeons working together, which is part of our whole concept behind Restore, are able to do these surgeries in under 4 hours without a Foley catheter. And largely in otherwise healthy patients, which most of our patients who are having breast reconstruction are fairly healthy, they can go home. And that's what I think we need to do. That's what places like Penn are supposed to do.
Yeah, that's an example of planting the flag on the moon right there. Yeah.
Yes.
Yeah.
Yeah, and I think Micro's come such a long way. Even when I just started, my goal was flap viability.
Yeah,
but
of course.
We're at an age now, though, where we know how to put these vessels together. For the most part, if they fail, I'm not, obviously there's technical reasons, but sometimes it's patient related, things you can't control. But so we really have, now I'm really thinking beyond that. Honestly, I'm not even fearful of flap failure now. I'm fearful of all the other things that come with it. Abdominal and donor site morbidity, patient getting a bulge or whatever, abdominal dehiscence, or the pain control, or the hospital stay for a few days. So I love that you're doing that, because we have to think beyond, just the microsurgical aspect of it.
Penn has always, part of it is the types of papers we write, but we've always been associated with quantity. 5,000 flaps, however many, and there's an importance to that, right? You need experience.
Low take-back rate.
And the low take-back rate, and the ability to study your outcomes. You need patients to do that, and we have them. Yeah. But that's been largely what we've been associated with. What I want this next period of our evolution to be is to be associated with superlative outcomes beyond just flap viability, beyond just number of cases. Let's plant that flagpole.
Wow.
So what advice would you give residents or fellows interested in plastic surgery or microsurgery from all of your years of contemplation, even when you're a kid listening to your dad and everything?
Well, stuff we've talked about. Number one, find a mentor. This isn't something.
How do you find a mentor?
Well, so you need to basically be active and involved and engaged, and not be
active.
and not be afraid of meeting with someone or talking to them at the end of grand rounds or stopping them on their way to something. And I think you'll find everybody's busy. Every faculty member, especially in academic center, is super busy. But we all remember how we started. And when you have a medical student or a resident who's engaged and is there and is asking good questions and wants that level of mentorship, I think most of us would easily reciprocate and find the time to be a good mentor. And many medical students have access to lots of different ways of finding a mentor. Number one, at their home institution. Number two, at away rotations. This is something but it's important to have somebody who you can bounce ideas off of, and it's too complicated of a field, and it's too long of a training to not have somebody guiding you throughout it. So number one is to get a mentor. And number two is to really think deeply about the kind of life you want. When it came time for me to decide between cardiac or plastic surgery, one of the big deciding factors was trying to think, okay, what does my life look like 5-10 years out in cardiac practice versus plastic surgery practice? And I have enormous respect for cardiac surgeons. To be honest, they do something I don't think I could do. And what I mean by that is, I'm pretty damn good at putting blood vessels together. So like the cabbage part, like the technical aspects of that part, I'm pretty sure I could do it. I'm pretty sure I could do it better. But that's not. But that's not what I'm talking about. I don't think I could. Based on how I feel, if a flap goes down, I do not think I could stomach it emotionally, psychologically.
Yeah.
If a patient died because of a technical failure on my part,
Yeah.
which is a reality of their life that they somehow have to find a way to manage, I think I would be a messed up person. And I'm glad I didn't pick that field. I liked it for all the same reasons I like microsurgery, and I wanted it for the intensity that it required. But that part of it, I don't think I could handle.
Yeah.
It takes a unique individual to be able to handle that well. And part of the challenge as a medical student, as a resident, is really, how do you get to thinking about that, right?
Yeah.
How do you get to that level?
You're
Like
thinking about so many other
everything
things.
seems cool and interesting and fun and exciting. But you got to think about, like, what does the life look like?
Yeah.
You know, and do you have what it takes, not just technically, but emotionally, to handle that, right? And I'm much better suited to plastic surgery, I think.
That's awesome.
It's important with everything that we're talking, you do hundreds of flaps a year. And now that I've gotten to know you really well, and I consider you a good friend, you're also an incredible dad, incredible husband, and you make time for that more important part of your life, because it's more important to me, honestly, is that other aspect. Although I love my job, I love what I do, but my family is always number one. How do you do it all? Like, how do you going into a week, like when you transition from Sunday to Monday, because I deal with this, how do you say, like, how do you maintain being a good husband, maintain being a good dad? What have you done for all these years, but still do hundreds of flaps a year?
This is a sort of a work-life balance question. And if you pit these two things against one another, then something loses, right? It's either, how do you balance your work and your life? And I don't think you can balance the two. So I have older kids now, and what I tell them is something my dad
One
told-
young one.
Yeah, one young one. What I tell them now is to figure out how much money they want to get paid per hour, right? How much is your time worth? And they'll, when I first asked them this question, they'd come up with some random outrageous number. And I would tell them that my time is worth an infinite amount of money. And that's because I can't get the time back, right? So that if I'm going to what does a job give you? A job, right, gives you, it takes some of your time and it compensates you with money at the end of it, right? So if those two things are true, a job can only do that. They can only compensate you with money. And my time is worth an infinite amount of money. There isn't a job that's ever going to be worth doing. If I'm trying to compete with time spent with my family versus going to a job, there's no way the job could ever compete with that, right? Because I would want to spend all of my time. And the reality of it is, the job's got to give you something more than money. And that's what this job does. It gives me something much, much more than money, which is the ability to impact someone else's life in an incredibly profound way. And for them to know that you did that for them, and for that relationship to build with hundreds and hundreds of patients. I mean, that's worth...
And residents.
And residents. And all of the aspects of my career. Like, I don't think I could do anything differently than I do now. And so when I come to work on Monday, it's not, oh my God, I wish I was home. It's...
So some Mondays.
Yeah, some Mondays. It's true. It's not realistic to say all Mondays are like that. But boy, if you're not thrilled to come to work most of the time, you got to find a different line of work to do. Because pretty soon, this is what happens. Pretty soon, if what you were doing it for was money, you'll make enough money. And then you'll want to quit. This is basically what every investment banker does. They go through, they're like, oh, I just want to make a lot of money. Then they do make a lot of money, and then they're 45, and they want to retire. And everybody like us, when we're in residency, are like admiring these dudes and basically saying, oh my God, I can barely afford to buy a car. Like, and this guy's retiring, and he went to medical school with me, and then he went to become an MBA, and now he's a CEO, or whatever. He's working for McKinsey, and he's like getting ready to retire. He's got a shore house, and I can't even scrounge up a down payment. Yeah. That's true. March out 15 years. How many really old dudes do you find at McKinsey? Or how many people are in their 70s do you find working for Goldman Sachs, except for like the one guy? Essentially nobody, right? They're looking for another career, something else to sustain themselves. They're becoming philanthropists. How many old surgeons do you see walking around here? There's a ton of them. There's a ton of them, right? I am going to die operating probably. There's very few jobs like that give you that sense. And like the problem is,
hopefully we're co-surgery again.
But my point is there aren't careers like that anymore.
Yeah.
You know, where you, and so if you don't, I mean, look, it's not realistic to always feel that way, but you want to try. That's what you're seeking. And when you put it in that perspective, then both of your life, like your work informs your life with your family, and your happiness and your family you bring into work, and it becomes all one big thing.
Yeah.
It becomes one big thing. And then all of a sudden I'm not thinking about balancing these things out. Now, that said, that's like a higher level philosophical thing. There's some practical realities, and it takes some time to get there. And when you're off balance is what burnout is. When you're off balance and you feel like one side's taking too much from you, well, then you start to resent it. And I'm 5 years in, I was enormously burned out. I didn't recognize it at the time, but basically I was just doing flap after flap. I didn't care what the outcome was. I just wanted to do more. And here's the thing. No one stops you. No one stops you from that moral hazard. Because if I'm doing the case fast, my residents are excited. If they get to do a lot and we're out of the OR, the nurses are happy, everybody's happy. Patients don't even hold you to account. Because the patients will basically be like, just so grateful I'm alive. I'm like, yeah, I know you're alive. I didn't have anything to do with that. Your flap looks terrible. Why are you not beating me up over it? Because they're just nice in general. And your boss, as great as he is or she may be, ultimately, if you're making money, they're happy too. Everybody is going to happily let you dig your own ditch. At the end of the day, you've got to have the wherewithal to realize, why is it that you're doing it? Are you actually doing it for the money? Are you actually doing it just for some random, like I did on hundreds of flaps last year? Is it like points that you're getting on some kind of weird video game? Or is there some actual purpose to what you're doing? And if there is, if you lose sight of that, that's what burnout actually is.
Yeah. Well, thank you so much for coming on the podcast.
My pleasure.
We have a few more questions that we're going to ask every single guest.
Okay.
So there's just some quick ones.
Yeah.
So I think we alluded to it a little bit earlier, but what is your go-to music in the OR?
Ed Sheeran.
Really? Yeah. I was not going to guess that.
I'm a big Ed Sheeran fan.
Wow.
Like super fan.
Cool.
Actually.
Really?
Yeah.
That's awesome.
Yeah.
He's great. I mean, he's a great. It makes sense because he's a fantastic guitar player. So.
You know what's cool about Ed? He wasn't.
Ed.
Yeah. I wish, right? He wasn't even the best student, like in high school, in terms of his variety shows in high school or whatever. Like he wasn't even good enough to make it to some of the things. So he wasn't even like the best in his own high school, but he just wanted it more.
Wow.
So he spent years living on people's couches, busking in subway stations, developing his sound until he became big. But like he just wanted it more than anybody else.
Awesome.
I love that story.
Yeah, that's amazing. Yeah. The next question is...
Yeah, what would you do if you didn't do plastic surgery or surgery in general?
I would.
You can't be a guitarist.
I would. No, I'm not. I'm not even close to good enough. But I would probably flip houses.
Yeah, that's a lot of fun.
Yeah, I mean,
that's cool.
I don't know.
Yeah, that's fun.
It's one of.
Yeah, awesome. And then our last question is, what's your favorite surgical instrument?
The ligature.
Oh, of course.
That's awesome. Well, thank you, Dr. Kanchwala.
My pleasure.
Awesome.
Thank you, guys. It was great chatting
thank
with
you.
That was a lot of fun.
No problem. Yeah.